This is Derek Srouji. Today I'm presenting my journal club on perioperative ischemic evaluation trial, or the POISE trial, which will be taking a look at the effects of extended release metoprolol succinate, toprol, in patients undergoing non-cardiac surgery. So just as kind of an introduction, I think it makes sense to everyone that non-cardiac surgeries, or just any surgery in general, will raise catecholamine concentrations in patients. The effects of that catecholamine increase in concentrations can have multiple effects on our hemodynamic parameters, mainly increased heart rate, increased blood pressure, and thus an increase in myocardial oxygen demand. There's been a lot of discussions and research throughout the years about the idea of whether beta blockers can help play a role in the attenuation of this catecholamine response, and if it can have an effect on the hemodynamic parameters of patients going into surgery, and whether that would have a beneficial outcome with the non-cardiac surgery. The majority of these studies were kind of kicked off, primarily the biggest study that looked into initially this thinking was the DECREASE-1 trial in 1999 that was followed up by the DECREASE-4 trial in 2009. These studies primarily looked at bisoprolol beta blockade in the use of patients undergoing intermediate risk non-cardiac surgery. These studies looked at a lead time of roughly 34 days leading up to surgical intervention, with titration of that beta blockade to allow for hemodynamic parameters targeting a heart rate of 50 to 70. I kind of bring up this lead time with time of titration because it'll become important as we discuss the POISE trial. This lead time gave them ample data points and information to at least more or better optimize their beta blockade to achieve certain hemodynamic parameters that they were targeting that will become important as we talk about the POISE trial. These studies established initially a 30-day benefit of reduced cardiac death and myocardial infarction. That was their primary outcome that they were looking at. However, in roughly 2014, when this data was kind of being reviewed, it was retracted from the scientific community for fraudulent information that was analyzed throughout their studies. Even though that this information was found to be fraudulent, it still brought up the questions of the roles of beta blockade in this idea of it being able to attenuate catecholamine response. Up to this point, or roughly in kind of the mid-2000s, 2005, no specific research had looked at the administration of beta blockade on the day of surgery. To this point, it had been with some lead time that allowed for different titrations of that medication. So nothing to this point had looked at specific administration of beta blockade on day of surgery, which brought us to the POISE trial that did try and look at this, this relationship. The clinical question for our study, the POISE trial, was essentially in patients undergoing non-cardiac surgery, does the use of perioperative beta blockade reduce the risk of cardiovascular events or death? And specifically, the administration of beta blockade on the day of surgery. So the primary outcomes for the POISE trial were threefold. It was mainly cardiovascular death, non-fatal myocardial infarction, and non-fatal cardiac arrest. That was our primary outcomes. There were a lot of secondary outcomes that we'll touch on that played a role in what the clinical application of this study and kind of the conclusions that came forth from it. But these were our primary outcomes. The study design, it was a multi-center parallel group. It was a randomized placebo-controlled study. It was a large study. The number of enrolled patients were roughly 8,351. The two branches were broken up into administration of toprol or placebo that were pretty evenly distributed, with about 4,170 patients distributed into each branch. Like I mentioned, it was a large study. It was conducted in 23 countries and over 190 centers. The enrollment lasted from 2002 to 2007, and the analysis was via intention to treat. The study criteria, it had a number of inclusion and exclusion criteria to be eligible for the study. The inclusion criteria was mainly age equal to or greater than 45 years of age. It had to be a non-cardiac surgery. Expected hospital length was greater than 24 hours. You had to have one of the following of coronary artery disease, peripheral arterial disease, or stroke. You had to have hospitalization for congestive heart failure within the previous 3 years. And then you had to have any of the following 7 risk factors that you can see listed below. I won't necessarily go through them, you can read them. Exclusion criteria, you couldn't have a heart rate chronically of less than 50 beats per minute. You couldn't have 2nd or 3rd degree heart block, asthma, or prior adverse reaction to beta blockade. It had to be a low risk surgical procedure. You couldn't be receiving a calcium channel blocker like verapamil or prior enrollment of POISE in the POISE trial. The baseline characteristics I've displayed here. The demographics were roughly 69 years of age of the patients admitted for the trial. Females only made up about 37% of the demographics. In terms of hemodynamic parameters, the average was about a heart rate of 78 beats per minute with a systolic of almost 140/80. In terms of distribution for past medical history for these patients, that included current smokers of 19%, essential hypertension 63%, coronary artery disease 43%, peripheral arterial disease 41%, and stroke of 15%. Patients that were diabetic and receiving either oral hypoglycemic agents or were on insulin made up about 29% of the participants. And then perioperative medications that patients were already chronically on included aspirin of 36%. They were on ACEs and ARBs of 44.5% of the time, statins 32%, diuretic 21%, and calcium channel blocker 22%. And both arms of either being administered toprol or the placebo were pretty evenly distributed in this for these characteristics. So there really wasn't much variancy between the 2 arm groups for these specific characteristics that they had enrolled in their study. So in terms of the methods that they used for this study and how the actual medication administration was underwent, the 2 arms were divided into the toprol group or the placebo group. The first administration of the medication was given 2 to 4 hours before surgery, and that was a blanket dose of 100 milligrams given before surgery with no titration of that medication. The only parameter that had to be met was that the patient had to have at least a heart rate of 50 and a systolic greater than 100. As long as they met those hemodynamic parameters and they got their administration of 100 milligrams before 2 to 4 hours before the surgery. The second dose was given roughly 0 to 6 hours after surgery, and that dose was 100 milligrams. Again, just kind of a blanket 100 milligram dose, as long as they met the hemodynamic parameters of a heart rate greater than 80 or systolic blood pressure greater than 100. If they did not meet those parameters in the first 0 to 6 hours, then automatically at hour 6, they were given that 100 milligram dose, even if they did not necessarily meet those parameters at that 6-hour window. Then, depending on when they did receive that first dose, whether it was between that 0 to 6 hours or at the 6-hour mark, 12 hours after that, they then received a blanket dose of 200 milligrams of the toprol. And then subsequently, daily toprol 200 milligrams continued for the subsequent 30 days after their surgery. There was a specific branch off caveat for that administration. If the patient was not able to tolerate oral medication in that 0 to 6 hour window, whether it be from coming off anesthesia, just not able to tolerate, or for whatever, IV administration of beta blockade was given Q6 hours with those same hemodynamic parameters administered. Of heart rate had to be greater than 50 and systolic had to be greater than 100. However, the study kind of showed some subjective measures of the administration of the IV dose. If they met, it was given to the physician to make a clinical assessment of whether they were able to tolerate either a rapid infusion of beta blockade in a shorter interval of time, then they receive that, or if they required a slow infusion pending their hemodynamics parameters. And the clinical study offers a lot of kind of subjective measurement of the clinician deciding whether they needed that rapid IV infusion or that slow IV infusion. However, as soon as that patient was able to tolerate PO medications, then they were switched back to the 100 milligram dosing and then the subsequent 200 milligram dosing 12 hours after the procedure. Here on this slide that you can see a couple different studies that looked, particularly in table 2, the adherence to study medication as they followed those patients for the subsequent 30 days after their surgery. You'll see temporary discontinuation of the study drug had a significantly higher proportion of patients being non-adherent to their medication in the metoprolol group of 18% compared to the placebo group of 12%. And that was largely secondary to patients being bradycardic or experiencing symptomatic hypotension that occurred in the metoprolol group with an estimation of 13% to 7%. And I bring that up because it will have kind of an impact on what our final clinical analysis of the study's primary endpoints. And then here you'll see on table 3 the effects of the study treatment and their primary and secondary outcomes that were discussed. And we'll see on the next slide in more of a graph distribution. But I just wanted to point out that our primary outcome that looked at cardiovascular death, non-fatal myocardial infarction, or non-fatal cardiac arrest did show an event rate of 5.8% in the metoprolol group as compared to a 6.9% in the placebo group. However, secondary outcomes that they were valuing in this study, namely symptomatic bradycardia and symptomatic hypotension, if we look down at those results, we had a 15% event rate for hypotension in the metoprolol branch as compared to a 9.7% in the placebo group. And then symptomatic bradycardia, 6.6% event rate for the metoprolol group, and then 2.4% in the placebo group. And we'll take a look at all those measures in our Kaplan-Meier curves here. I've displayed our graphs A through D that look essentially at different outcomes. Our A being our primary outcome, which I mentioned was looking at cardiovascular death, non-fatal MI, and non-fatal cardiac arrest. These other graphs displayed the Kaplan-Meier distribution of secondary outcomes that were of clinical importance to this trial. Namely, our graph B looks at myocardial infarction, graph C looks at stroke, and then graph D looks at death. Going back to graph A, looking at our primary outcomes, we had a hazard ratio of 0.84 that essentially looks at a moment in time of our ratio of our outcome of our two branches. So in this case, our metoprolol group versus our placebo group. You can see on the y-axis, we're measuring risk distribution, and you can see an early divergence of our Kaplan-Meier curves where placebo shows a higher risk distribution as we move along our x-axis of our time interval and our number of patients at risk that are measured at each time interval that are still being followed, that are meeting our parameters that we've outlined. The 95% confidence interval for that primary outcome was 0.7 to 0.99 with a p-interval of 0.0399. So then moving on to our graph B, where we're looking at our secondary endpoint of myocardial infarction. Again, you see a early divergence of the Kaplan-Meier curve for placebo relative to our metoprolol group, signifying an increase in risk of myocardial infarction in patients that were in the placebo group. The hazard ratio was 0.84 for this graph, and you can see the confidence interval data listed below. As we move to our table C and table D, you'll notice a reverse of originally what we're examining here. You'll see early divergence of our Kaplan-Meier curves, but now we're seeing our hazard ratio is increased above 1, indicating that now our primary drug administration of metoprolol is showing an increased risk relative to stroke in patients. And then here again in our graph D, where we're looking at death, our hazard ratio being 1.33, we again see a divergence in our Kaplan-Meier curves, signifying our metoprolol group having an increased risk in patients that were followed for the 30-day segment relative to the placebo arm. So taking all of that information in together, I think the conclusions of this study really focused on the idea that perioperative use of beta blockade can reduce the risk of our primary outcomes and risk of myocardial infarction. However, as you saw, there is, that does come at an expense, namely death, stroke, and clinically significant hypotension and bradycardia. Patients who, when approaching patients about this idea, patients who would place 3 times more value on avoiding perioperative stroke or other secondary outcomes that we discussed, rather than avoiding myocardial infarction, may then find benefit to this medication that that this study was trying to emphasize. However, it's pretty clear that yes, beta blockade on the day of study or on day of surgery may have some beneficial effects pertaining to our primary outcomes, but it does come at significant risk, mainly clinically significant hypotension, bradycardia, possibly leading to stroke. And that was the kind of primary conclusions that this study was alluding to. There were a handful of criticisms that I think come from this trial. The biggest thing that I found that was a criticism was this blanket dosing of the medications, either prior to surgery or then shortly after in the post-operative stage. As I mentioned in the decrease trial, they at least had given a lead time of roughly 30 days where they had the ability and data points to titrate to specific hemodynamic parameters. And this, obviously, looking at beta blockade on the day of surgery really gave no data points to have optimal titration of that beta blocker. It was really just a blanket dosing given to these patients. So really no space for titration. And that can obviously impact our clinical studies and conclusions that we come from this study. There was a significant difference in discontinuation rates between the 2 control groups, or between the 2 arms of the study. As we kind of alluded to before, the metoprolol group had 18% discontinuation in that 30-day follow-up as compared to 12% of the placebo arm, and mainly that discontinuation was linked to clinically significant bradycardia and hypotension found in those patients. I think the study was slightly underpowered. Originally, they had tried to find 10,000 patients for their study to create a relative risk ratio of 25, or relative risk reduction of 25%. They mentioned in the study that they were okay with 8,000 participants because it could reach their power or their clinical significance. And then as they collected data from the different centers, there was a number of centers that they had issues with, particularly 752 patients in 6 hospitals in Iran and 195 participants in 3 out of 11 hospitals that were being monitored in Colombia were ultimately excluded for fraudulent activity and reporting of their data through their 30-day follow-up, which kind of just raises the questions of what else could have been either excluded or what else was being included that may have not been accurate information. And then just to touch on what the current guidelines regarding perioperative beta blockades in patients undergoing non-cardiac surgery. These are from the ACC and HA guidelines that essentially say patients on chronic beta blockers who are undergoing surgery should continue taking their beta blockers They mentioned that it's reasonable to manage beta blockers after surgery with guidance by clinical circumstances, regardless of when the beta blockers were initiated. And then some other guidelines that you can kind of read through, but then on the bottom here, you can, they discuss explicitly, they do not recommend starting beta blockers on day of surgery. So I think there's a lot of information that comes from these studies, but from my own personal opinion, I think there's just a lot of adverse effects that have been shown from these studies relating to hypotension, bradycardia, obviously the potential of stroke as secondary outcomes. And I think it's, in my opinion, a little risky, especially when we don't have good titration protocols for patients being initiated beta blocker for the first time on day of surgery. So that's my journal club topic, and I'm going to go ahead and turn it over to Dr. Chronister and Dr. Connell to further discussion. Thank you.
That was fantastic. So this trial, maybe not the sexiest thing in the world, but it's fun. And it reminds me why I like doing journal clubs. There's a lot of meat on the bone with kind of design and bias and doing things illegally so that you can get to be the head of the European Society of Cardiology. Like, it's great. It's wonderful. I tell people a lot that we don't know a lot in medicine. There's a lot of stuff that we think we know or that we have some evidence for, but the more that we dig into data and research, we find that we're basing most of what we know off of minimal evidence, uncertain evidence, or evidence that's not 100% correct. So a lot of things become anecdotal until we get these big randomized controlled trials to prove or disprove our hypotheses. The POISE trial was the first big trial looking at this that was ever done, really. Prior to that, we've had physiologic studies that I think we all feel decent about prove that sympathetic activation occurs with surgery. I think that makes sense. You have surgery, your sympathetics go into overdrive, and that's just kind of a physiologic response to getting surgery. We've had observational data and retrospective data that has showed correlation with sympathetic drive in surgeries with worsened cardiac outcomes. And so we use what's called the Lee criteria, or the Revised Cardiac Risk Index, RCRI, as we risk stratify patients with known or at-risk cardiovascular disease to see what their perioperative mortality is. So the RCRI is something that we use to demonstrate 30-day risk of stroke, heart attack, or cardiac arrest post-surgery in patients with cardiovascular risk above the age of 45. So it's something that we do quite often, or that the surgeons do, and that we should be doing. So we see that correlation. That was done since the 1970s. So once they started looking into the idea of, well, let's find a class of medicines that can reduce sympathetic activation or reduce the clinical outcomes that occur because of the sympathetic activation. So beta blockers make sense. That was started to look at in the 1990s. As Dr. Srouji said, the REDUCE trial was the biggest study up to that point. That was in the mid-90s with a follow-up study done several years later that showed benefit with bisoprolol. The lead scientist on that, physician, his name was Don Poldermans, ended up getting kind of ostracized and kicked out of every clinical position he's ever had because he was fabricating evidence and not following guidelines for his own studies. So we don't know what those studies, how impactful they are. So we do the POISE trial, 8,000 people. Up to that point, pretty much every study looking at beta blockers in this population of patients was about 2,000 people. So this is about 80% of the people that we have ever looked at this on in the POISE trial. It does, as Dr. Srouji said, show reduction in non-fatal cardiac MI at the expense of death, hypotension, stroke, and hypotension. It's a hypotension bradycardia. So then if you kind of dig into that, you can say with a straight face, don't give beta blockers perioperatively if you're not honest to begin with, because you're going to increase your risk of dying and having stroke. And that makes sense, but it's not potentially 100% true, because we're basing it off of this study. And this study was weird in that it gave to a person who's never been on it 100 milligrams of toprol followed by 200 milligrams of toprol the day of surgery, which is interesting. So in that circumstance, in that cohort of patients, I agree, it does that. If we look more ad hoc and post hoc analysis, we see that about a third of patients who had stroke and MI or stroke and death happened because of hypotension, which probably happened because of surgery in the setting of starting a very high dose of metoprolol succinate. So I think the question could be asked, because physiologically it makes sense, beta blockers are helpful to reduce MI in the setting of adrenergic enhancements. What if we started at a lower dose? Would that give you the benefit without the downside? I think that's still a relatively good question to ask. And so most of the patients in this study were an RCRI of like 1 or 2, which gives you about a 6 to 10% risk of 30-day bad outcomes. So I think you could ask the question of people who are RCRI of grade 3 or above. They give you a 15% risk in 30 days. Would they benefit from low-dose beta blockade? Current guidelines kind of restrict our ability to go gray on that, but I think it's a relatively good question that has some validity to it. So I agree. My practice is what the guidelines are. I don't do it for people who are not on beta blockers. If someone's going to have surgery in 4 weeks and they have otherwise an indication for a beta blocker, I would potentially use 4 weeks as my starting time. Otherwise, I don't give beta blockers perioperatively. But I think there's a lot more meat on the bone to look at clinically, and this question is not answered 100% in my opinion.
Okay, so I'm going to talk a little bit about the stats. Can you go back to your Kaplan-Meier curve graph? That's what I'm going to talk about. So you did a great job talking through kind of what those graphs are telling us and how stroke, death, etc. they flip on us, which is really interesting because most studies, when you look at a Kaplan-Meier graph, they tell you the same thing. It's just the degree of what they tell you. Rarely do you see your control group and your intervention group just completely flip-flop like this. So I think a couple of points here. What is your primary endpoint? Knowing what your primary endpoint in a study is important because this was a composite. And so you look at just the primary endpoint, which is the point they're studying. Looks great, no big deal. And then, but you can see that that's driven by MI. So you get to stroke and you go like, what the heck happened? As Dr. Chronister said, probably was driven by the fact that they got hypotensive. I think the other thing with Kaplan-Meier curves is those curves as they move represent either an event or censoring. And so censoring is somebody falls out of the study because of XYZ related, not to the study. So they decide to move to Timbuktu. Okay, well, we don't have a study site in Timbuktu. You're censored out of the study. On some Kaplan-Meier graphs, you'll see ticks that represent that, and then the full drop or raising, depending on how the curve is. On this one, you can actually look at the numbers at the bottom and how many people drop out. So actually, you can talk about powering, underpowering, but at the end of the day, not that many people were censored out of the study relative to the whole number. So when you see, let's take stroke on the bottom left-hand corner there in window C, when you see that huge jump there of that cluster, that's either because a whole heck of a lot of people had strokes, a whole lot of heck of people got censored, or our population is just too small. Because if this trial were 200 people in and there's 100 people in each arm and 2 people moved to Timbuktu, well, you're probably going to see that. And so looking at how many people dropped out, were censored, versus how many people had the event, versus, okay, are there enough people in this study that I actually think that jump in stroke is real? Again, we can talk about power. Was it underpowered? Was there fraudulent stuff going on, right? Those are all kinds of fun ethical questions asked. But at the end of the day, they still had 4,000 people in the study, and they showed a lot of strokes at around day 3 or 4. And so I think when you look at a Kaplan-Meier graph, just be careful of what you're looking at, because this study, I don't think manipulated it too much, but I have read studies that really manipulate it, where if you actually look at the far numbers on the right, you can see that there have been a ton of people that have been censored out. So then you have to ask the question, well, why were they censored out? Did they just not like the drug? Were they having side effects? And how is that being manipulated into your data? Is this data being manipulated? Maybe it is, maybe it is not. Maybe if we chose a different dose of metoprolol, we would have different results. But just be careful when you're looking at Kaplan-Meier curves, because they're really cool and they can give us a lot of information. But just like all statistical information, they can be mislabeled and misused and made to say a lot of things that we don't actually think are true. So it's just kind of my thought on Kaplan-Meier curves for the day. Very good job.
Thank you.